Now that we're a few weeks into this COVID-19 crisis, some experts are starting to think about whether this global pandemic might actually provoke us to do some things quite differently, maybe much better, once it passes. One area that could be ripe for change is virtual medicine. And joining us now to discuss what that might look like is Dr. Aman Sidhu, who's a respirologist with the University Health Network's Transplant program, and she joins us on the line via Skype from her office at Toronto General Hospital. Dr. Sidhu, good of you to join us tonight. How are you doing today?
Thanks, Steve. Thanks for having me. I'm doing well, thanks.
Glad to hear it. Why don't we start by you just telling us off the top what your mission is essentially at UHN?
Sure. Our mission really is to be able to leverage the virtual care tools at our disposal to be able to provide the best patient-centered care and maintain excellent outcomes for our patients. Our goals really are to be able to improve access to care, to provide that care closer to home, and try to avoid unnecessary hospital visits for our patients, all while trying to improve patient experience and outcomes.
Now, do I infer from that that a great deal of the Ontario healthcare system, as it's currently constituted, involves very much a focus on face-to-face contact between doctors and patients, nurses and patients, and so on?
It still does. You know, we are lucky in Ontario to have access to the Ontario Telemedicine Network, which is one of the largest telemedicine networks in the world. And so we have for many years been able to do things like virtual video visits with our patients. But there are issues with the system design and also with the comfort level of patients and providers in accessing and providing virtual care. You know, face-to-face care is what we're all used to. It's most typically how physicians are compensated. But we have to remember that face-to-face care is often very provider-centric. You know, you come to us, take a day off work, pay the parking fees, um, and we really have to look at virtual care as an option to provide care and get the knowledge out there that it's something that's available in Ontario, and that maybe should be used more.
Well, it's ironic. Maybe I should ask you rather than saying it, but does it feel ironic that it takes a global pandemic for virtual care to get a shot in the arm? I know, for example, I got an email from my general practitioner who said, if you're feeling like you've got the symptoms of COVID-19, do not come to our office. So is this, in some respects, an opportunity for those who are boosting virtual care?
Absolutely. And a lot of us who have an interest in this area have been discussing it, that it's, you know, obviously a very challenging time, but this is really going to present an opportunity for providers to examine their workflows, examine their patient populations, and look to see where virtual care can really fit into their practices. And it sometimes does take a push, um, like the pandemic, to be able to make that shift quickly. And so I hope we all use this opportunity to learn more about virtual care and continue to really leverage it in the post-COVID era.
Now, you mentioned telehealth, which I guess is the most basic kind of virtual care where somebody phones in and gets some kind of consultation over the telephone. But what else might virtual care involve?
Well, virtual care really is a term that broadly describes any of the interactions that patients and providers can have. That might even include interactions between two care providers who look after a patient. And when we talk about telemedicine, it's not just the phone lines that offer advice for patients, but it's also the availability of a platform where we can do video conference visits with patients. Virtual care might even involve asynchronous communication where you can send your care provider a text message question that is not urgent and they can get back to you, to replace playing phone tag. It can involve even remote monitoring of patients where they are enrolled in an application and able to enter their biometric data. You can look at that in almost real time and make treatment decisions based on how patients are doing at home.
Now, the logic of this and the convenience of this seems rather compelling. So why has it been so sluggish in being implemented?
Well, I think there are a few different reasons. One is surely the level of comfort that people have. Some people will say that they don't feel that they can provide the same care in person as they can virtually. And really, I think we have to think of virtual care as not a replacement for what we do in person, but as a complement to what we do. We have to think about how we can integrate it into the care that we already provide. There historically were probably some issues with people being able to access video conferencing equipment, but now with I believe it's about 90% of homes in Canada who have internet access and a similar number approaching who have smartphones. This is less, the technology aspect is less of a barrier.
Hmm. Well,
Physician
let me
remuneration. Oh, please.
yeah, hold off on physician remuneration. I'll get to that in a second. But I can just imagine people watching this or listening to this right now saying, wait a second, there's no way that you can diagnose a problem I've got as well or as effectively virtually, in other words, through a Skype feed or over the phone, as if I come into your office. What would be the response to that?
Well, I think, again, it's not that virtual care is meant to totally replace in person care. I think there are some areas of healthcare where you could almost go entirely virtual. Imagine the impact on mental health services and access to those across the province. There are other scenarios where, of course, in person care is going to be very important. If someone needs to have a physical examination, that will change their management. If patients need to come in for procedures, I think we have to think of the uses for virtual care. For example, if somebody came to see me in consultation in person and I organized some tests, I might be able to arrange their follow up virtually to discuss those test results and to arrange treatments as opposed to making them come back into my office when I don't need to examine them again.
Hmm. Now, one thing I've heard from a number of medical professionals over the years is that they have been strongly urged not to do this. For example, do a consultation on Skype over an abundance of concern about privacy issues by the Ministry of Health. Could you speak to that angle in this story?
Yes, sure. So historically, platforms like Skype or WhatsApp have not been considered secure enough to do video visits with patients. What we have used is the platform that's delivered by the Ontario Telemedicine Network, whereby a clinician has an account and does the interaction using their platform and their software. Now, in the COVID era, we're all providing care with whatever modality we can to look after our patients. What I would say, and what we do tell our patients, is that there is no form of virtual care that's going to have perfect security and privacy, similar to when you're doing online shopping. There's always some inherent risk. And so we discuss that with our patients when we're undertaking virtual care. We also have some advice to say, look, if you're going to have a visit with us virtually, make sure that you're doing it in a private environment. Make sure that you're not using a shared device or a shared network, say on in a coffee shop, and that those things can all improve the security aspect of things.
Do you think, though, that the Ministry of Health is sort of hyper vigilant about this? Are they overdoing it?
Well, I mean, I think vigilance is very important. I think what may come out of the COVID pandemic is realizing that there are very secure platforms that are available to a lot of us, typically through our electronic medical records systems that have integrated video capabilities. And I think what we will see is that the ministry will start allowing the use of these platforms more and more.
Now, you mentioned the codes earlier, and let me get into that because, of course, physicians get paid when they treat a patient because there is a particular code for each treatment, which they then send to the Ministry of Health. The Ministry of Health recognizes those codes and then remunerates the physician accordingly. Are there, in fact, adequate codes to deal with this right now so that if physicians provide this service virtually, they can actually get compensated for doing so?
Actually, there are. And so I'll talk a little bit about pre and post COVID. But the physicians have had the capability to bill the government for their services that are rendered over the Ontario Telemedicine Network platform. We don't have in Ontario specific virtual care codes. We use the same codes as we would for an in-person visit, but just have to denote that it was done virtually. What's happened with COVID to try to improve our ability to look after patients remotely is that the OMA and the ministry have negotiated emergency fee codes whereby we can bill for visits that we're doing virtually over Skype, over FaceTime, or even telephone visits similar to what was occurring during SARS.
Well, here's the next complicated question then. Should a doctor be compensated as much for a virtual visit as she should if the patient were to come into her office?
I think that for a similar consultation, we can really provide the same service virtually versus in person. Now, the caveat for that is that we really should be triaging our patients and trying to figure out who can be looked after appropriately virtually and who needs to come in person. It's a little bit different with the current pandemic in that we're trying to look after as many patients as we can virtually. Um, but I think the key really is to being able to select patients down the road. And I think a lot of us are going to learn more about how to do that because of what we go through during COVID.
Yeah, I mean, not to focus too much on the money here, but the reality is that my hunch is you can see potentially twice or even three times as many people virtually as you might if they were to come into your office, just because of the convenience of doing it. And if that ends up costing the Ministry of Health, therefore, twice or three times as much in physician compensation, maybe that's why they're dragging their heels on it. Does that make sense?
Well, I think on the other side of that is that we may be able to increase capacity. Our clinic space is finite. And so there may be a respirologist who is seeing patients in person in our clinic, and there's no further space to see patients that day, but another person could be seeing patients who need to be seen virtually. We tend to book our clinics similarly to if they were in person in terms of the time and the volume. And so, I don't think that should be a major barrier for the ministry.
Okay, Dr. Sidhu, let's finish up on this. If you and those who think as you do on this issue have your way, take us a few years down the road. How do you see the healthcare system perhaps being transformed by a much greater accent being placed on virtual care?
I think the possibilities are really endless. There are options to do home care almost entirely virtually through collecting things like biometric data and managing patients, in their own homes. I think we're going to be able to provide services more and more like teledermatology, where we can look at patients' skin and diagnose conditions virtually. I think there's even a role for tertiary care centers to provide support for inpatients and clinicians in other hospitals. For example, a very experienced intensive care doctor here in Toronto might support smaller communities. It might go so far as some places in the U.S. that have entirely virtual hospitals. They house no patients, but all they do is assist with remote monitoring, telemedicine, and they're completely virtual.
Well, it's interesting. I was emailing with a doctor the other day who, as it happens, is Canadian, but is in South Africa right now and is still consulting with patients, treating patients, monitoring patients virtually. And, they're half a world away. So the possibilities, as you point out, are quite endless. Dr. Sidhu, thanks a lot for coming on to TVO tonight and helping us out with this. We're really grateful for your time.
Thank you very much for having me. It was a pleasure.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.